Okay, it's in the next half an hour or so, I'll try to provide a brief update on the cancer-associated thrombosis. These are my disclosures. I'm a medical oncologist, so I'm still in the right meeting, and I've been paid an honorarium to attend a meeting, a roundtable conference on BMS-sponsored cancer-associated thrombosis at board. So cancer-associated thrombosis, or CAT, it's a real problem. We know that patients with cancers and are having a higher risk of thromboembolic disorders, including that includes PE or DVT. Epidemiological studies show that there is a 4 to 7-fold increase in the risk of VTE in cancer patients compared to general population. And even in the cancer patients, there is 1/5, 20% higher risk or cumulative incidence in a year period of these events, the PE and DVT. In the patients who are on treatment for VTE, there is still an increased risk. And also, more importantly, there is increased risk of bleeding in these patients. Again, the hazard ratio quoted ranges from 2 to 4. So around 2 to 4-fold increase in the risk of bleeding in cancer patients who are on treatment. And all this morbidity result in mortality, where there is an excess of around 4,000 deaths caused in cancer patients due to VTE, and it's close to home in the UK. In the next few minutes in my time, I'll just briefly talk about the available evidence, and ideally, I would like to open the floor for discussion because there are more unknowns here than any knowns here. So the CLOTS trial, again, I'm not going to be preaching the converted here. We all know that's the first trial that's nearly 20 years ago now that showed that low molecular weight heparin was far better than warfarin in the management of venous thromboembolism in patients with cancer. And these are the pivotal results where we can see that patients with oral coagulation, oral anticoagulants, which we read as warfarin, had nearly doubled the higher risk of VTE. And it's like any clinical researcher's paradise to see this kind of curves where you see such a wide separation of the events in the form of Kaplan-Meier curve. So widely, immediately, it was reasonably, without much debate, embraced as the standard of care in patients with cancers. However, in the last decade or more, the initially called NOACs, which is no longer novel, now it's direct oral anticoagulants, they have been investigated extensively in cancer patients, and in the order of alphabetical order, Edoxaban, Rivaroxaban are the widely investigated Zabans, as we call it, or DOACs in cancer-associated thrombosis. The results of the Caravaggio trial, which was the most recent one to be presented by the investigators and published in NEJM, gives us very sound basis of use of DOACs in CAT. I'll just show the patient's demographics here, just to illustrate that this is very much typical of the DOAC-based trials, in such that all the patients had active cancers, and either they have been on treatment or on follow-up for active cancers. This is a well-represented cohort, around 1,170 patients, equally distributed between two groups, between Edoxaban and dalteparin at the standard dose. Edoxaban was given as 5 milligrams twice daily, which again is a standard dose. Patients were very fit, mostly with ECOG performance status 0 or 1, which means that they were either without having any restriction in their activities of daily living, or a limited restriction without requirement for rest or hospitalization. The patient's characteristics in terms of cancers, they did exclude patients' brain metastasis, because there is perceived to be an increased risk of bleeding with these patients, and patients with non-melanomatous skin cancers and hematological cancers were excluded. The key result was to show that the use of apixaban in dalteparin versus dalteparin was non-inferior. So again, if we look at the bottom curves, that's the actual events, and the insert expands the y-axis a bit so that we can see the curves separating. And for statistical and clinical purposes, I don't think there is a huge separation of the curve in the first few events, and the p-value here for non-inferiority is statistically significant in such that the risk of recurrence of VTE in apixaban treated patients compared to dalteparin was favoring apixaban treated patients. The absolute risk was 5.6% compared to 7.9% in the dalteparin treated patients. So around 37% reduction in the risk of death. This trial was not powered for superiority, so it has to be interpreted as a non-inferior trial, which meets the primary endpoint. The other key endpoint is the safety here. And when we go to the safety outcomes, it showed that unlike other drugs, which we will talk in the subsequent slides, the use of apixaban was not associated with increased risk of major bleeding. So 3.8% of patients in apixaban compared to 4.0% of patients in the dalteparin had suffered major bleeding, and that is not statistically significant. The definition of the major bleeding is accepted as per the International Society for Thrombosis and Hemostasis, which is requirement of greater than 2 units of blood transfusion or a drop of greater than 2 units, 2 grams per deciliter of hemoglobin, and or bleeding in critical sites, i.e. brain, etc. And the non-major or major non-gastrointestinal bleeding also was fairly similar in both these treatment groups. So overall, in the primary safety outcome, the use of apixaban did not seem to be associated with increased risk of bleeding. There are numerically higher patients in the non-major bleeding. These terms are good to be objectively monitoring the risk of bleeding and hemorrhage. But as a patient or as a clinician, to a patient who has a bleeding, having hemoptysis and or hematemesis or indeed hematuria, any bleeding is distressing, whether it is warranting admission to hospital or whether it is warranting a review to the A&E. So it's still clinically significant for the patients and of course the clinicians. So there was an increased risk of a non-major bleeding on a numerical manner, but not statistically. So the other study is on the Edoxaban, which is the investigators from Hokusai VTE cancer group, and it used the DOAC of Edoxaban compared to dalteparin. It was one of the first major phase 3 trial, and it had a composite endpoint where they included major bleeding and or recurrent VTE as their primary endpoint. And the trial was designed to show it is non-inferior, or if it is if the p-value was greater than 0.087, it was be superior. So essentially it was designed for non-inferiority. And it showed that the composite endpoint, when we include both VTE and bleed, it was not significant. So Edoxaban was equivalent to dalteparin. But when we look into the detail, when we try to dissect the 2 independent events, risk of recurrent VTE, again, DOACs fare better in such that there was a 29% reduction in the risk of VTE when Edoxaban was used, and the confidence interval do cross the unity as in 1.0 there. But again, this is the composite endpoint is what the primary endpoint of the study. If you look at the risk of major bleeding, there was again a higher risk of bleeding in patients treated with Edoxaban, around 6.9% in the Edoxaban treated group compared to 4% in the dalteparin treated group, and it was just statistically significant. Again, that's not the primary endpoint there. The last of the 3 DOACs, it's Rivaroxaban. It's a very much a homegrown study conducted in the UK of around 200 patients, where they compared Rivaroxaban against dalteparin in the patients with cancer. So here, the primary results was looking at VTE recurrence. So it would appear that dalteparin had fared poorly compared to rivaroxaban. And again, there is a theme emerging that the DOACs are definitely better than low molecular heparin in controlling or in reducing the risk of recurrent VTE. Looking at the risks of bleed, the rivaroxaban was indeed associated with increased risk of bleed. Again, numerically, 11 patients in the rivaroxaban group and 6 patients in the dalteparin group had major bleeding, and the clinically relevant non-major bleeding was significantly higher in rivaroxaban group. Now, where does that leave us? Now, looking at all this data, these are the kind of the hard data that we have to have phase 3 RCT guided evidence in a domain which so far have been slightly paucity of evidence is good. So the guidelines from different international bodies have rapidly embraced the use of the DOACs. So the American Society of Hematology, which is the most updated one, which was published after the Caravaggio, i.e. the apixaban results, have included DOACs, apixaban or rivaroxaban in the initiation phase, i.e. in the first week, and in the treatment phase, the 3 to 6 months, which we can talk about the duration of treatment. They have included all the 3 DOACs, and they have preferentially recommended these DOACs over low molecular heparin. In terms of the extended phase, they've again give the ongoing risks with the thromboembolism in cancer patients. They recommend indefinite use of DOACs or low molecular heparin. The National Comprehensive Clinical Networks, primarily US and Canadian, North Atlantic guidelines, also pretty much say that you could use low molecular heparin or rivaroxaban or apixaban in the initial phases. However, they do advise use of low molecular heparin in over DOACs, and in patients who refuse low molecular heparin, they suggest DOACs. So there is a variation in the kind of even amongst the oncologist and the hematologist across the pond in the use of or in the recommendations. Coming to NICE, NICE suggests that we use anticoagulation for at least 3 to 6 months. And they preferred, this was even prior to the Caravaggio results, they advised DOACs, and also they give a disclaimer that there is the use of DOACs in cancer patients is off-label, but it's recommended. So they have suggested using a low molecular heparin. In terms of the duration, if it is provoked or unprovoked, that again, I think we'll talk about that in the next few slides. The ASCO guidelines, which is our key guidelines, the American Society of Clinical Oncology, suggested use of DOACs, rivaroxaban or edoxaban or low molecular heparin. This was in 2020 prior to Caravaggio results. So I'm pretty sure when it is updated, it will include apixaban as well. This is where our RCT and our level A evidence stops. And then we have a situation which are extremely clinically relevant, but it becomes gray. Sorry to use the slides, which in case we are not very clear, it is gray because we don't have any evidence, or we have by consensus or by multidisciplinary approach in this group of patients. So there are multiple nuances or multiple factors that we need to consider. It's not as complicated as the case presentations that we heard previously from our gynecology colleagues, but these are not without the complexities. So we need to consider the site of the cancers. Typically, the patients who have had bleed or these cancers, which is called the luminal cancers. I had the upper and lower gastrointestinal tumors and the genitourinary cancers. And even in this group of patients, the esophagogastric seem to be having a slightly higher risk compared to the colorectal cancer patients. And in genitourinary patients, bladder cancer and renal seem to be having more risk, but then numbers get smaller and smaller. Patients who had their primary removed, as in patients who had a colectomy or a gastrectomy, obviously will have a reduced risk of bleeding because their primary cancers have been removed. The patients with brain metastasis, unfortunately, these are like a Cinderella group here, and these patients, unfortunately, are poorly served in any clinical trial, whether it is an oncology-based trial or whether it's an CAT-based trials, because these patients have portend a poor prognosis and they have a very unpredictable course. And so, to homogenize the clinical trial population demographics, patients with brain metastasis are excluded, and the with the increased risk of bleeding, low molecular weight heparin seem to be generally advised, but there is emerging evidence from longitudinal studies and observational studies that DOACs can also be used. DOACs, obviously being an oral medication, one has to consider the swallowing issues, but with the use of this DOACs in patients with stroke and CVA, where they have swallowing difficulties, these are administrable through a nasogastric tube. So this per se would not be a contraindication for DOACs. The key consideration from an oncological point of view is the drug-drug interaction or the pharmacokinetic interactions. Now, DOACs are substrates for cytochrome P enzymes and the P glycoproteins. And these are the enzymatic pathways that are extensively involved in the ADME, the pharmacodynamic and pharmacokinetic interactions in cancer. Whilst these studies, the Caravaggio, the Hokusai, and indeed the SELECT-D studies have involved patients who have been on active systemic anti-cancer treatment, the SACT as we call them, there are patients these patients with cancers who are on the so-called targeted therapy or the biologics or the tyrosine kinase inhibitors, which are a significant group of our armamentarium of the SACT, and which are indeed either inhibitors or substrates of the cytochrome P and the P glycoprotein. There is a significant, at least a theoretical concern about the drug-drug interaction. So again, this is a situation where we need to have a friendly pharmacist who is keen, knowledgeable, and gullible to a degree, who might be able to look into the interactions and advise us. Or we can, there are some tools widely available, the Liverpool Cancer Interaction Checker, where you can check for the interaction. A word of caution, though, is that these drugs, particularly the oncological drugs, they're fairly new, and not much might be known about their interaction. So we need to go by possibility of the theoretical mechanistic actions. And for the same reason, the patients who are enrolled to clinical trials with investigational medicinal products, IMP, for cancers, because there is no unknown risk for patients' interaction with DOAC, where either the efficacy of DOAC could be reduced, resulting in increased risk of VTE, or other way, where the efficacy of the IMP, the cancer medicines, can be reduced, resulting in poorer efficacy and outcomes for cancer patients. The clinical trials, as a rule, exclude patients on DOACs. Again, when the tide is changing and when we are moving on to DOACs in cancer patients, cancer patients should not be excluded from a clinical trial because the patient is on a DOACs. And in these cases, unfortunately, the patient don't have an option but to go back to on a low molecular weight heparin. We have had excellent talks about the kind of the body weight previously, particularly the overweight and also the lower weight, and that has a direct impact on the hepatic and renal impairment. The hepatic and renal impairment situation is not hugely different in non-cancer patients to cancer patients, but only that with the cytotoxic drugs and the targeted drugs having a plethora of side effects, including immunotherapeutic drugs, there is a dynamic change in the renal functions and a dynamic change in the hepatic functions. So we need to be cognizant of that, and we need to be watching it carefully, and dose modification can be considered appropriately. The same applies to the cancer cachexia as well, where patients who are bad enough and experience significant weight loss, and with the benefit of the systemic anti-cancer treatments, where they derive a good clinical benefit, when the weight changes, we need to be dynamic in changing the dose. And again, here the trials do exclude patients who are in the other extremes, less than 50 kilos or greater than 150 kilos. And we have to extrapolate the data from the normal population. The unresolved question is about the duration of the treatment with anticoagulation. Now, cancer patients are pro-thrombogenic patients. Without boring too much about the physiology, they are having a hypercoagulable status and venous stasis. They are not hugely mobile as normal patients, and they have vascular damage due to the cytotoxic drugs and also the targeted drugs. So they are highly vulnerable for VTE, and their risks of that's nothing called unprovoked, although we see within quotes incidental PEs and DVTs in cancer patients. These are not truly unprovoked. The provoking factor is the cancer. And unfortunately, the metastatic cancer patients are the largest cohort of the patients that we see in clinics compared to the radically treated curative intent patients. So the risks remain, and the treatment should factor in the risks of the VTE and also the risks of incidence of VTE due to the systemic anti-cancer treatment that we use. The Hokusai study was the only study that allowed treatment beyond 6 months. It allowed patients up to 6 to 12 months of treatment based on the investigators' discretion. And so there is some evidence that these drugs can be used beyond that in an RCT setting. There are a few trials ongoing, notably the APICAT study, which is looking at apixaban after the initial first 6 months, but at the reduced dose. So again, this is where we need to perhaps have a patient-tailored approach on a case-by-case basis, but predominantly with the risks and the provoking factors that continue throughout their limited life, many times to reduce the morbidity of the recurrent VTE, we would advise the continuation of anticoagulation. Clearly, that has to be factored against the risk of bleeding. Any talk in the current era cannot be complete without mentioning the C word. Previously, the C word was cancer. Now the C word becomes COVID. So the impact of COVID, it's on not just the vaccine-associated thrombosis and the risk of thrombosis. It's also about the therapeutic interactions. So the commonest use drugs for COVID, at least prior to the antivirals, in hospitalized patients is dexamethasone or steroids, and this can interact with DOACs because both go in the cytochrome pathway. So there is there is early recommendation, perhaps, that in the acute phase when patients are being the patients are ill enough to be hospitalized, it is preferable not to use DOACs. But once the acute phase is treated and dealt with, consider switching back them to DOACs. So again, a dynamic approach is needed. All of this is very good when we have access to all the drugs, but the access and the formulary practices vary between different boards and the local practice. So we just need to be cognizant of the use widely. For example, if GPs and the primary and secondary physicians are widely used to Rivaroxaban, it can be a challenge to move the patient back to apixaban or even edoxaban. The other thing about is the treatment at end of life. Patients, again, metastatic patients, it's a burden to have even within quotes a non-clinically significant bleeding, because when they're already sadly dying, the last thing they want to go through is an hemorrhagic event. So we need to have an open discussion with the patients whether it is appropriate to have a continued treatment with the DOACs or indeed any kind of anticoagulation. So the way I kind of see it is a visible effect, i.e. the bleeding, versus an invisible effect, i.e. the PE or the or to a degree the visible DVT. Again, whenever we don't have any evidence, we go by consensus, and that's where we need the multidisciplinary approach. And again, this has been talked about widely in the previous talks. So when we need a team-based approach, which includes obviously the hematologists, the pharmacists, the radiologists, the vascular surgeons to answer questions about IBC filters, and of course, keeping the patients focus, having this clinical nurse specialist as well. So a truly multidisciplinary approach in this kind of setting is definitely warranted. Speaking of which, the practice varies in different centers in some respects. Without blowing our own trumpet, in Glasgow, we are quite gifted to have a kind of a well cohesive functioning thrombosis committee under the realms of whom we have drafted the updated guidelines of the treatment of prophylaxis of VTE in cancer patients. So based on the evidence that we have just discussed previously and the guidelines, we have adopted that we could use either Edoxaban or dalteparin in patients with active cancers who are either on follow-up or receiving systemic anti-cancer treatment, SACT or radiotherapy. To now avoid disadvantaging patients who have been in the clinical trial who otherwise cannot participate in trials because of the concomitant use of DOACs, dalteparin can be used. I think at this stage, I would stop my talk and I open the floor for discussion and questions. Thank you for listening.
Thank you very much, Bala. That's a really nice overview. And we've got about 10 minutes for some questions. There's one question on the chat which asks, are DOACs safe to use in cancer-associated thrombosis associated with GI cancer malignancy? I think you touched on that in your grey slide, but could you just elaborate on that a little bit? Because it's a frequently asked question and people write that into algorithms that DOACs are contraindicated, but from my mind, it's once they're treated, it seems to be safer. Could you comment on that?
That's an excellent question and very practical question. So the initial DOAC-based trials, particularly SELECT-D with Rivaroxaban and Hokusai VTE with Edoxaban, both of them did demonstrate that there was an increased risk of bleeding with GI cancers, particularly the upper GI cancers. However, the Edoxaban-based Caravaggio study, which included significant group of patients with upper GI and lower GI malignancies, did not demonstrate an increased risk of bleeding. So Edoxaban is still safer to use in this group of patients. However, in patients with primary cancer in situ, we clinicians do get a bit understandably concerned whether to continue with DOACs or switch to low molecular heparin because reversibility is easier as well. So Edoxaban is safe to use in all cancer groups, including GI and GU, genitourinary cancers. But if there is a significant concern that the primary is untreated, either with surgery or radiotherapy, it is not unreasonable to move on to low molecular heparin.
Okay, thank you. And I think there's some more questions coming in actually. Someone's asked, are there any studies in patients on chemotherapy? And I was going to link a question myself about, what are the commonest drug interactions you're finding, and do they then make, if you see there's a class of drugs that interact with DOACs, do you move then to low molecular heparin? The question is, are there any studies in patients on chemotherapy from? So
all the studies, both the large phase 3s and the smaller phase 3s, have included patients on systemic anti-cancer treatment. And if we look at the appendix of these divisions, it covers the commonly used systemic anti-cancer therapies, the taxanes, the cisplatin, the 5-fluoropyrimidines. These are the commonly used drugs. And they also included the biologics, the TKIs, but then they are less than 10%. So we are not seeing any specific class effect with certain group of systemic anti-cancer treatments, but we know that the monoclonal antibodies, the immunotherapy and the targeted therapies, these MABs, which are large molecules, do not have any specific interaction with any pharmacological agent, so they are okay. But when it comes to the IPS, the cabozantinibs or sorafenibs or the tyrosine kinase inhibitor, they do have a risk of interaction, and that's where we need to phone a friend with the pharmacist or indeed look into the interaction checker ourselves.
Okay, Got another question. What will be the dose of DOACs in thromboprophylaxis in cancer patients?
That's an excellent question. I kept the talk mostly on the treatment. We have not done the thromboprophylaxis or the particularly beyond. It's very clear at the initial acute phases, the first 6 months, but there is this open question: what happens after the 6 months? Particularly, do we kind of mitigate the risk of bleeding by reducing the dose? There are ongoing trials. The APICAT trial is looking at that. It's a reduced dose, 2.5 milligrams of apixaban compared to 5 milligrams. So this is an evidence-free zone, but the practices vary, where there are certain guidelines which say that you can reduce the dose, but that's based on limited evidence, in my opinion. I'm happy to be updated by our learned hematological colleagues here.
There's lots of questions coming in for you, Bala. So popular talk, I think. Someone is asking about PICC line-associated thrombosis, guidelines for treatment, and how long should be the duration of treatment.
Yeah, the catheter-associated thrombosis, or the PICC line or central venous associated thrombosis, it's a real problem. Again, because it's a foreign body. So previously, the recommendation was that we try to take the line out and then anticoagulate for. They accepted. Again, this is such a small group of patients, but clinically relevant group of patients. There is no trial evidence for that. But the consensus opinion, I hope Dr. Andy Cohen is in this meeting still. I think we had a recent roundtable meeting. I think that we agreed the consensus should be at least 3 months of anticoagulation in this group of patients, and if we can salvage the line.
Yeah, okay. Thank you for that. Now, the next question from James Tiernan, who's my colleague here at the Royal Infirmary of Edinburgh. He thanks you for your great talk. What he wants to ask about is the concept of being cancer-free as a means of informing decisions to stop anticoagulation following a cancer-associated PE, but it could be VTE, any type of VTE. Should we be thinking 6 months following curative cancer treatment? Should we extend to a year's duration, awaiting follow-up imaging? How do you tend to approach these scenarios? Is James's question.
Again, extremely relevant question, and unfortunately, with the patient group that we have, it would be a delight if we have a multiple group of patients in this situation, but we know that we don't remain in the situation of having a curative discussion with the patients. But the approach would be, one, what is the burden of disease? Do they still have active cancer? And with the advent and the wide use of immunotherapy, that we use the word curative, we still look for what we call, within quotes, long-term control, and where the burden of disease, where this patient have a complete response without any evidence of radiological disease on scans, and they are treatment-free. So in those group of patients, the risks of VTE is significantly different or significantly reduced compared to a patient who has a low burden cancer, but still on active treatment. So as a rule, patients who are on systemic anti-cancer treatment, be it for low burden disease or high burden disease, it is difficult to stop them on their anticoagulation, simply because their risks from the cancer and also the systemic treatment remains. In terms of, I think the specific question about what do you do if they had, within quotes, cure, as in long-term control, I think it's reasonable to stop the treatment after 6 to 12 months, but this is a personal opinion. And this is where we need to have a chat with the patients. There are certain cancers like CNS cancers, pancreatic cancer, although in these cancer groups, unfortunately, we never can aspire for a cure or long-term control. But renal cancer, these are extremely prothrombotic compared to prostate cancer or breast cancer. And perhaps in a patient, younger patient without any recurrent disease, adjuvant treatment, classical example in breast cancer, it is impossible to kind of consign them to lifelong anticoagulation. So for adjuvant breast cancer patient who had a clot triggered by adjuvant chemotherapy, after the completion of chemotherapy, it's totally appropriate to stop after 6 months. So a case-by-case based approach is what we might need to adopt here.
So once again, we're hearing very individualized decision making for patients, and we've heard that coming through all the talks today.
And maybe phone a friend as well, phone a friendly hematologist.
Thank you. A final question, I think we've got time for this, is do we need to use anticoagulants in thrombophlebitis in cancer patients?
So again, certain cancers, particularly pancreatic cancer, is widely associated with thrombophlebitis, and this again, it might feel like a parrot here. We are having a paucity of evidence here with these patients, and probably in this is the case where I will have to defer to the hematologist about this. I see Colin Church there. I don't think Catherine is any other hematologist there to answer this question.
Well, I guess I can help. I mean, I probably would use thrombophlebitis much in the same. I would use an anticoagulant much in the same way in a pregnant lady with thrombophlebitis. We use an anticoagulant rather than an NSAID. I think it depends on the extent and it depends on the circumstances again. But for thrombophlebitis, we often do some imaging, make sure there's not an underlying DVT, and then look at the proximity of the part of the thrombosis to, for example, a saphenofemoral junction or something like that. So there'll be lots of different factors involved in the decision making, but one of the things is these patients can be hypercoagulable. So I would tend to look at the circumstances of the patient and probably opt to use an anticoagulant, but that would be my own personal view.
Yeah, I think similar views is what we do for the pancreatic patients where the higher risk of thrombophlebitis migrans, but that's not that common with other cancers.